Assalamu alaikum. Welcome to the Ocular Trauma module. My name is Dr. Ahmad. I'm the head of the Department of Ophthalmology at Shalamar Hospital. So today's module consists of 8 components. As you are aware, that these are not the only injuries that the eye can sustain, but we have highlighted the key ones that you should know as an ophthalmology or an emergency room physician who has to deal with acute trauma injuries coming through the door. So this module consists of evaluation of open globe injuries, other complex injuries involving the eye, foreign bodies, corneal abrasions, chemical burns, retrobulbar hemorrhage, traumatic optic neuropathy, and some discussion of orbital fractures. All right, so let's start with open globe. So this is one of the most feared ophthalmology emergencies just because of the fact that it has guarded visual prognosis in a lot of cases. If you even suspect an open globe, it is critical that you do a quick exam before you even take the history. If you do suspect a ruptured globe, call ophthalmology right away, and in the meanwhile, place a shield over the affected eye. Do not patch the eye. You do not want to apply any excessive pressure over a potentially ruptured eye by patching it. So a simple shield, like a pirate patch over the eye, is sufficient to avoid any added pressure. Make sure, meanwhile, you're waiting for ophthalmology to come, that you have ensured that the patient's tetanus immunization is up to date. You can order IV antibiotics, especially in the case of contaminated wounds. Regardless, it should be done. Narcotics may or may not need to be given depending on the severity of the injury and the pain being experienced by the patient. And antiemetics are very important to prevent any further pressure on a potentially ruptured eye. You should call and book a room in the theater and call anesthesia to evaluate the patient. Inquire about the time of the last meal to see if the patient can safely receive anesthesia, and you should prepare their hospital admission. Now, moving on to open globe. An open globe may be obvious, as the initial cases I will discuss, or it may be very covert. So let's start with obvious open globe injuries. You may be able to see a penetrating eyelid injury. In some cases, the eye may look just fine, but all you can see is an entry wound in the eyelid. So make sure that you examine these eyes thoroughly, because there could be an occult foreign body in the eye. In the case below, over here, you can see that this child has a bullous subconjunctival hemorrhage, which resulted after a fall. And in this particular case, it may signify a very severe orbital trauma, which may or may not be associated. In this particular case, unfortunately, it was with severe globe rupture. This is another case of a patient who presented with a bullous subconjunctival hemorrhage. And in this case, it resulted from a fight, which caused severe globe rupture that actually extended far posteriorly into the globe and unfortunately could not be repaired. This particular eye was enucleated within 2 weeks to reduce the risk of sympathetic ophthalmia. Now, it is really important to note that a lot of these cases do go on to become medical legal cases, especially when the eye needs to be enucleated. Most of us ophthalmologists do not advocate for primary enucleation because you go in, you explore the eye, and you give the patient time to mentally absorb the fact that they may lose this eye within the upcoming period. Sometimes they seek a second opinion. And we do have a cutoff of about 2 weeks post-trauma to enucleate the eye to prevent the risk of sympathetic ophthalmia in the fellow healthy eye. In another case, this patient also sustained a blunt force trauma. And here you may look for a shallowing of the anterior chamber or even blood inside the anterior chamber. So this is a slit magnified view. This is what we would normally see when we have access to a slit lamp. And as you can see, there's a layering of the red blood cells in the anterior chamber, which is shown with the white arrow. And this again indicates a trauma severe enough to cause bleeding inside the eye. Another part of an exam for a ruptured globe is or a sign is a peaking of the pupil. So this particular patient came in looking pretty nice and quiet. The only unusual thing in their exam, they reported a history of a fight and they had come in for an eye exam. And on exam, the eye appeared relatively quiet except for this iris. So as you can see, the patient had actually a penetrating wound from a knife. This results in a peaking of the pupil, and this peaking usually points towards where the corneoscleral defect is. And over here, you can see there was iris actually incarcerated within the wound. If this is an isolated injury and these people get timely treatment, this type of a patient can actually have pretty good prognosis. Another severe type of injury is iridodialysis, where there's disinsertion of the iris from its root. So it's important to understand anatomy if you know if you are going to be treating patients who are walking through the door. So tissues of the eye are organized into concentric rings, like the inner tube of a tire. And whenever there's blunt force trauma to these inner tubes, the intraocular pressure will obviously rise, correct? And this causes the globe to expand and stretch these concentric rings. And when they stretch, if there's enough force, they can actually rupture. So what has happened over here is that the circular tissues around the iris actually tore away from the root from approximately 5 o'clock all the way to around 8 o'clock. We usually label structures in the eyes in terms of o'clock. So this would be 12 o'clock, 3 o'clock, 6 o'clock, and 9 o'clock. And you can see that this dark area over here represents the tear from of the iris from its root over here. This is a very severe form of trauma, and this can lead to a lot of complications for the patient, not just a cataract behind, but also very high chance of glaucoma developing in the future in this patient. This type of trauma can and should be repaired. Finally, we come to one of the more dreaded parts of the eye exam, and that is when you notice a retinal detachment. So a severe ocular trauma may cause the retina to tear and detach. And in this particular patient, they had a penetrating globe injury while they were mowing the lawn, and you can see an entry wound over here. And they were mowing it with those automated machines, lawnmowers, and there was an object that flipped back into the eye and entered the eye, causing the retina to tear and detach. And you can see the retina as this orange mass behind the lens. This is another unfortunate case of an elderly patient who just presented with this deformation of the eye and loss of vision. And if you pay careful attention to the history, the patient will just tell you that they just walked into a door and their vision is now down. But on careful exam, you can see that the eye is usually pressurized like a ball. And you can see how it started to deflate over here. This patient actually had a penetrating keratoplasty, which is a corneal transplant in this eye, and it had ruptured because of the blunt trauma. So again, very guarded visual prognosis in a patient like that. So whenever you're looking at a patient, you're trying to stratify, is this mild, moderate, or severe trauma? So one of the things to look out for in terms of the severity of the trauma is the eye exam. And if you palpate the orbital rim and you notice any signs of discontinuity, or if you see that the medial canthal tendon is detached, those are both signs of severe orbital trauma. Next, we move on to what other clues can you get in terms of whether or not the eye is ruptured? Sometimes the eye looks very nice and quiet. All you notice is a slight shallowing of the anterior chamber, for example. In those cases where you suspect an occult injury or you see a small rupture within the cornea itself, you can do something called a Seidel test with fluorescein strips. Again, these are usually tests that are reserved for ophthalmologists who are seeing these patients in the emergency room. So a Seidel test involves applying fluorescein, diluted fluorescein into the eye, and a positive test can detect leaking aqueous or even exposed vitreous. So over here, the concentrated orange fluorescein actually becomes bright green under cobalt blue light. So this patient clearly has leaking of aqueous and pooling of this fluorescein over here. And this fluorescein is actually staining the aqueous humor that's leaking from the eye. Another thing we worry about with open globes is presence of foreign bodies. The patient's history is really important. A lot of times the history will tell you whether or not it's a metallic foreign body or a non-metallic foreign body. And at your level, you are aware that MRI is contraindicated for metallic foreign bodies. However, in those cases, sometimes the simple things are the most helpful ones. An X-ray of the head or CT can be done to locate the presence of a foreign body. Usually does not require any sedation, is quick, and you get some useful information. So let me give you an example of this particular patient over here. This patient had come in with a penetrating eye injury from a metallic fragment while hammering metal on metal without safety glasses. This I have seen several times in Pakistan. And in this case, sometimes the defect is not very obvious. So even as an ophthalmologist, you have to be very comfortable with the technique of retroillumination, where you project light into the pupil and you look at the reflected light for any particular defects in the tissue. And over here, we see where the arrow is, a retroillumination defect within the substance of the iris. This particular patient's history was really interesting because they actually appeared to be having a very normal eye exam. The anterior chamber was formed, the vision was good, and yet we see this retroillumination defect. So we have to search high and low in this kind of a patient for a retained intraocular foreign body because the entry won't conceal. This is another good example where a patient had an X-ray of the head and was noted to have a very clear, small, well-defined foreign body within the orbit itself. This is a metallic foreign body because it's showing up on the X-ray. And please keep in mind that, especially in certain cases, these may be medical legal cases. If you suspect a foreign body, make sure you look for it thoroughly because later on it can be said that you missed seeing a foreign body. So use the radiologic techniques at your disposal to try and identify a foreign body that may not be easily visible. This is another unfortunate case of a patient who had a shotgun injury to the right eye. And you can see these very disorganized contents of the anterior chamber over here. You cannot make out really any good iris details. There's bullous subconjunctival hemorrhage over here. And this particular case, unfortunately, the eye was ruptured beyond repair. And again, due to this unsalvageable eye, it had to undergo an enucleation. This is another example of a shotgun injury where a couple of retained shotgun pellets are seen. One is over here, this is subcutaneous, and this is intracranial. And the right globe over here also is grossly deformed as compared to the fellow eye. This patient had a globe rupture after being hit by a car. The right globe, you can see, is very proptotic, meaning it's pushing out. It's actually, there's so much chemosis that it's actually pushed the eye down. And the anterior chamber details are not seen. The whole eye appears black because it's filled with blood. Again, guarded visual prognosis, and this eye had a globe rupture. This is a CT. So this particular patient underwent a CT scan. And as you can see over here, this blue arrow shows you a very deformed right eye with hyperdense signals within the eye indicating bleeding and clot formation. So sometimes you may get lucky and the foreign bodies are more superficial. So if they're not impaled within the substance of the tissue, you can easily remove them using irrigation or a wet cotton swab if it's visible to you and you can easily have access to a slit lamp and remove it. With corneal foreign bodies, only if they're not embedded, you can use a wet cotton swab, or you can use special jeweler's forceps to remove these foreign bodies. Typically, removal is followed by installation of antibiotics, so like a quinolone 4 times a day with follow-up with ophthalmology. Unfortunately, if there are any infiltrates present in the cornea, then a lot of times these are considered dirty wounds and we will need to culture the base of the wound. The patient may not have presented right after the foreign body went in their eye. So again, for corneal abrasions, if there's a superficial foreign body, it can be removed under a slit lamp biomicroscope. In this case, you always have to make an effort to evert and sweep the eyelids and the fornices to make sure you're not missing any hidden foreign bodies. Any loose epithelium that's present is debrided. Cycloplegics are typically given for pain because a lot of times these patients do have ciliary spasm. You cover them with topical antibiotics, typically for a week to 10 days. Any infiltrate present, as mentioned before, is cultured, and you follow this kind of daily until you notice an improvement. Now, this is something I really want to mention. A lot of times when a patient walks in with trauma, we're all hyper-focused on the one eye that appears to be injured. A lot of times the fellow eye may also have some level of injury, but you have to give that eye a thorough eye exam also and make sure you're not missing out any occult foreign bodies, any occult breaks, any anything else that could be wrong with the eye that you wouldn't know without an eye exam, even if the vision is 6x6 or 20/20. Next, we move on to serious burns of the eye. These include chemical burns. Now, it is important to know that there's a grading system for chemical burns, which I will discuss later. And this grading system is based on the exam before you start irrigating the eye. And the management is, as soon as you get a call that a patient is there with a potential chemical burn, immediately start irrigation of the eye with Ringer's lactate or normal saline. To try to go through at least 2 liters, wait for a few minutes, and then check the pH using litmus paper. And you can put the litmus paper in the inferior fornix, and you keep doing irrigation until you achieve a pH between 7 and 7.5. The fornices of the eye should be swept for any kind of particulate matter. The eye pressure should be checked. The warning signs are if you start to notice ischemia or whitening around the limbus, any epithelial defect in the cornea, haze in the stroma of the cornea, or inflammation in the anterior chamber, which indicates the depth of penetration. So this is a case study. This patient was at work and had an eye burn covering this particular area as well as the cornea with concentrated anhydrous ammonia. So this was an industrial accident, and you can notice that there's some necrotic tissue over here, and then there's a small area of inferior limbal ischemia right over here, and there is an epithelial defect involving the cornea right over here. There was, you could see the iris and the pupil details on exam very well. This is considered a grade 2 ocular burn. So when we compare acid injuries to base injuries are actually much more worrisome because bases can penetrate much deeper into ocular tissue. The grading of corneal burns is based on the extent of limbal ischemia, which indicates the extent of corneal stem cell loss and how much haze there is left in the cornea. So this is a classification system designed by Hughes, and it's a nice, simple classification. Grade 1 indicates very good prognosis. There's no corneal opacity or limbal ischemia. Grade, again, good prognosis. Usually there's some corneal haze, but iris details are clear. Less than 1/3 of the corneal limbus has undergone ischemia. Grade 3 is guarded visual prognosis. There's sufficient corneal haze to obscure iris details. Approximately 1/3 to half of the corneal limbus has become ischemic. And unfortunately, grade 4 injuries are the most severe and very guarded or poor prognosis. The cornea is completely usually opaque. You cannot see the details of the iris or the pupil. And half or more than half of the cornea has undergone ischemia. Next, we move on to severe injuries leading to retrobulbar hemorrhage. So whenever a patient presents to you with an intraconal hemorrhage, meaning a retrobulbar hemorrhage, the eye starts to become gradually or quickly proptotic. This is because of accumulation of blood behind the eye. The eye starts to feel extremely hard, so it's not soft to palpation. We talked about the progressive proptosis. The patient, if they are not obtunded and they're awake, will tell you that they're starting to lose vision in that eye. And if you're able to dilate the pupil and take a look at their retina, you will start to see that the central retinal artery perfusion may be starting to go down, and there's a whitish appearance of the retina itself. In these cases, you check the eye pressure, check the vision, check for RAPD. And the management is, if the pressure is starting to go up, the eye is starting to become proptotic, and you have either done a CT scan, and even if you haven't, sometimes these patients need a bedside or an emergent lateral canthotomy with cantholysis. And a good emergency room physician should have the skill set or should be able to call ophthalmology urgently to be able to perform this. Next, we move on to traumatic optic neuropathy. So traumatic optic neuropathy is an injury that damages the optic nerve that carries the vision from the eye to the brain. So a severe blow to the superior orbital rim can transmit this force to the optic canal. On CT over here, this is a great example. This is CT without contrast, and you can see over here that there's a bony fragment on the optic nerve or sheath on the optic nerve. It can also be a small, I think there's also a small sheath hematoma, and this is right at the apex over here. These kind of cases will usually present with an afferent pupillary defect. There's very severely guarded visual prognosis. It is controversial whether or not steroids are helpful. Generally, they are not helpful, but some people attempt, because as a last-ditch effort, to IV steroid with spinal injury protocols to try and see whether or not steroids may reduce inflammation and maybe reduce some pressure on the eye. But if there's a bony fragment severing your optic nerve, there's very little you can do to help that patient, unfortunately. And just one more note, make sure you go over these CT scans with a radiologist, ideally one who is very comfortable examining orbits, and make sure that you see this yourself before you say that the patient has a traumatic optic neuropathy. Now, we've been discussing very obvious cases so far. Now, some cases are kind of occult. And this is a case of a child who had been elbowed in school one day prior. He came in complaining of some pain in the eye. He said that the pain got worse whenever he tried to move his right eye. He was having some double vision. You can see his Hirschberg test over here. And he had some nausea and vomiting whenever he was trying to look up. And these are WEBOFs, or wide-eyed blowout fractures. A lot of times these occur in children where there may be limitation of extraocular motility. This occurs because of entrapment of muscles, which, if not treated, can lead to ischemia and fibrosis and lifelong consequences. So this is the same child who has been asked to look up. You can see there's no bleeding, there's no swelling in or around the eye. When asked to look up, the left eye is able to look up, but the right eye is restricted. And the CT scan of the same patient shows you that the inferior rectus is trapped on the floor, within a floor fracture over here. Open repair is required for patients with functional diplopia that does not improve as the swelling resolves. These fractures, which involve more than 50% of the floor, may result in significant enophthalmos and should be considered for repair. Fractures should be repaired within 2 weeks of trauma, with the exception of the white-eyed blowout fractures, which are considered an emergency. Most fractures which are repaired would require some kind of an implant, and there are various new implants available. There are mesh ones, there are fiberglass ones, there are numerous other implants. We try to use the most biocompatible ones because a lot of times these implants are going to be in the eye for the rest of their life. Floor fractures a lot of times are also repaired in conjunction with ENT because they usually involve the maxillary sinus also, and sometimes the ENT doctors are able to approach it much more easily than an approach from the globe itself. So the orbital fractures, other than white-eyed blowout fractures, you can generally wait 5 to 7 days for the swelling to come down. And floor and medial wall fractures are typically repaired only if there is, number one, significant enophthalmos, meaning that the eyes, when you compare them, the affected eye is sunken more than 2 millimeters. If the floor fracture is very large, so if it involves more than 50% of the floor, you should try and repair it because with time, the eye will start to sink in and the patient can develop diplopia. And at that point, it may be more difficult to repair because the tissues have fibrosed and have reorganized. Number three, if there's entrapment on the CT scan, as shown in the previous CT, and there's restriction in the movement of the eye. So when you do forced ductions, the test is positive, or you can elicit the oculocardiac reflex. So while these patients are in the emergency room, you should tell them to avoid nose blowing or sneezing because that can cause air to accumulate under the tissues, making the eye exam harder and can actually increase the pressure in and around the eye. And you should also consult oculoplastics. So this is an example of a patient who had a trapdoor fracture, which is a floor fracture. Over here, it's shown by the arrow. They also have some blood in the maxillary sinus. You must be familiar with Lefort type fractures. There's type 1, 2, and 3. Type 1 do not usually involve the eye or the orbit. Type 2 and type 3 can involve the nasolacrimal system. You should check not only palpate the orbital rim above and below the eye, you should also check for facial sensation and trismus. And if trismus is present, make sure that you have ruled out a zygomatic maxillary complex fracture. Nasoorbital ethmoid fractures can also cause traumatic optic neuropathy and can also involve the nasolacrimal system. So this is an interesting photograph that shows you the protective mechanisms that we have within our skull. So this particular older patient suffered a softball injury with subsequent fracture and compression of his ethmoid sinuses. You notice that the bridge is kind of pushed in and compressed, and the nose and the ethmoid sinuses actually provide like a speed bumper for the brain. So they absorb a lot of the blunt force and prevent trauma to the brain. And this kind of fracture actually is trying to protect your brain and the delicate intracranial structures. Over here, you see a coronal CT scan of the face and the orbits, and this patient actually had a zygomatical maxillary complex fracture. These arrowheads show you the multiple fractures sustained by the patient and the fact that the maxillary sinuses is filled with blood. This is a coronal CT of a patient who had, this is not very commonly seen, an orbital roof fracture. And there was very marked intracranial hemorrhage, as well as some intraorbital hemorrhage over here. This patient was in a fight and developed a medial wall fracture. As you're aware, this is lamina capricia. This is one of the thinnest walls in the orbit, so it's very prone to fractures with even mild trauma. And unfortunately, this particular patient developed some entrapment of the medial rectus muscle, and this has to be repaired. Again, whenever there's entrapment of the muscle, it usually needs to be repaired. This is one of the last slides, and going over the various different types of fractures and what you should be on the lookout for in terms of clinical signs. So I want to thank you for your time. And if you have any further questions, I'd be happy to answer them in person. And I hope you learned something. We're happy to share these and other kinds of trauma with you if you visit the eye clinic. Take care. Thank you. Bye-bye.